I'm here to talk about what is it going to be like when we have conferences where it's not all talk about food. And so, first of all, the necessary disclosures. My funding comes primarily from government sources in Canada and the US. And I also put here the Canadian Celiac Association, which has been really important, and I think highlights the importance of patients really getting behind things, because having that support is what's led to getting more government support. I also have collaborations with Biomedal and Glutenostics, and I will be talking about their products in this presentation today. So quickly, an overview. I want to start off with, is a gluten-free diet enough? And then a little bit about how does an idea become a treatment, which helps us understand when we're looking at what's in the pipeline, how far is that from us having that and having our gluten too. So where next after that will be the final thing. So to start off with, celiac disease has been around, we think, for at least about 2,000 years. The first archaeological evidence dates back to the year 100 in Italy. And it really wasn't until the 1940s that the gluten-free diet was delineated as the treatment for celiac disease. And you'll notice that there's not really anything on this timeline between 1940 and 2017, and that's because we really don't have much more to offer than the gluten-free diet today. And so I think it's a cause for pause. It also tells us a little bit about celiac disease, because it used to be the teaching was there was 3 Ds for celiac disease: diagnosis, diet, discharge. It's a very unique condition because management is much more on the shoulders of the patient than it is of the physician. And there's no prescriptions, there's no medications, which is fantastic, but it also means that there's nobody coming back to the physician and saying, you know what, I'm following a gluten-free diet as best as I can and I'm still having symptoms, which means I think it's taken a while to recognize that maybe a gluten-free diet is not enough and we can't stop there and we need more. This is actually a figure from one of DOGGIE's first papers about the gluten-free diet. He presented case studies. This is a child who had various hospital admissions, during which he had a gluten-free diet and did well. This was really the turning point admission, because they not only had him admitted and were feeding him, but they let him go to school. And that's where they discovered that he was getting gluten at school, which I think is a very early sign that gluten-free diet is really not enough, because we don't live in controlled situations all the time. I think that many people have experienced many of these situations. This is some work we've done in Boston, where we asked patients with different diseases, just in the context of their disease, how much of a burden was it to follow through with the treatment. And these patients didn't know that we were comparing them to patients with other conditions. You can see celiac disease is on the far left. And this is one of those times where maybe it's not so good to come in number 2, because number 1 is kidney disease, which means patients on dialysis felt like they had a lot of treatment burden, but they were the only ones that rated the treatment burden, on average, higher than the patients with celiac disease. And that includes some significant conditions, including diabetics who are taking insulin. So clearly a difficult treatment. And we also know that patients don't get better. This is some data from our centers, Beth Israel, adults on the left, looking at non-responsive celiac disease, which is people who, after 12 months on a gluten-free diet, still have symptoms. And you can see the biggest reason is actually gluten exposure, which again is telling us there's something about the gluten-free diet that we just can't get it right. We also know that probably the most important thing is to have healthy villi, which means doing a biopsy and having a look is the best way to see how people are really doing. And if we look at studies of people where they've been biopsied, we see that about 1/3 of people have ongoing mucosal damage, even when they've been following a gluten-free diet for 5 years. So that's not very good. And when we ask patients, if you're following a strict gluten-free diet, most patients will say yes. But then when we say, how often do you get rare accidental gluten? Or how often do you, less than once a month, intentionally have gluten for whatever reason? We find that that's actually up to 1/4 of patients, which again, you'll notice we're getting 1/3, 1/3, 1/3. It's an important number, and I don't think 0.666 is a great batting average. The Red Sox aren't there, but it's not good enough for celiac disease. This is a study you've seen before this morning as well, asking patients how happy they are to take a gluten-free diet, because really, ultimately, my patients aren't generally happy to have tall villi. They're happy because they're happy. And when we look at this, we see that actually most patients are kind of flat or maybe a little bit unhappy, and there's very few in that far right column who are absolutely ecstatic and delighted with a gluten-free diet. I would argue a gluten-free diet is not enough. So the question is, how do we move past the gluten-free diet? Like everything else, the first step is you have to come up with the idea. And this is where many of us spent many years trying to come up with our great ideas, and when things go wrong, occasionally spend some time there too. And so I wanted to take a moment to really talk about how do you take an idea to actually being a treatment that you have a patient who can take, and what's the pathway to get there, because I think that'll put into context where we are and where we need to go. So most things start out in the lab, the test tube, animal studies. We have a lot of great computer modeling now, but there's a gap between that and actually having a treatment in the patient's hand. And so the first step in really triggering the process, and I'm going to talk in the context of the FDA approval process. It's different internationally, but the principles and the steps are generally analogous. The first step in the United States is to really file an application with the FDA saying, we have something, here's the data that we think it works in animals, we want to test it in humans, and here's our plan. And then we need two groups of people. First of all is phase 1 trials, and this is typically healthy volunteers. So people who don't have celiac disease who are otherwise healthy. And then the next phase is when we actually get it to patients. And then after it's been approved, there's further supervision, but that's well beyond where we are for celiac patients. So before we get to the human stage, we really want to find out what's the toxicity, what's the dose. These first early steps in volunteers, we're looking at how is it absorbed, how is it excreted, what are the side effects. The next phase, when we finally get to patients with celiac disease, we're looking at, first of all, does it work? And then second of all, which patients does it work for, or does it work for all patients? And so, of course, this takes time and also takes money. These figures at the bottom are for the average drug. You can see we're getting well over the $250 million range. And this is an important thing to remember, that this is for a successful compound, and most compounds fail. And so for any individual compound to get to market, it's on average a $2.8 billion investment. So it's not something that's small in terms of money or in terms of human effort. So where are we with celiac disease? We know that there's things that seem to lead to celiac disease in some way. We can see tissue transglutaminase, we can see cytokines, we can see these immune cells mixed in with those intestinal cells, and we can recognize that triad of vellus atrophy, deeper crypts, and these immune cells as celiac disease, but we don't have a good explanation for how we get there. And the reason this is important is because if we don't know how celiac disease happens, it makes it more difficult to treat it. And so that is reflected in the types of treatments we have. So this is something that you may not be able to see very well, but we'll go through it step by step. Essentially, in the circle are different strategies for treatments for celiac disease, and then on the outside are some examples of some compounds or some medications that would apply to that strategy. So these ones have really not progressed to humans. They're primarily something that's being done in animal studies. So they're not really important to talk about today. This group here are treatments where the ones that are available are primarily directed towards people who have refractory celiac disease. Now, refractory celiac disease is different than non-responsive celiac disease. It's rare to the point that some of these compounds they've had trouble testing because they literally can't find enough people globally to do a trial. So those aren't necessarily what we need to talk about today. Which leaves us with these ones, which are elimination of gluten and different ways to treat gluten, which we have the gluten-free diet, and we know that when you change gluten, it's not gluten anymore. It doesn't stick things together, it doesn't taste good, so that's not necessarily a winning strategy. We then have anti-inflammatories and really repurposing medications we already have, but not really anything new or anything specific for celiac disease. And then in the miscellaneous categories, I'll just point out one of the ones on the list there is pancreatic enzymes. And we do currently have a trial going on at Beth Israel looking at pancreatic enzymes for non-responsive celiac disease. So if you have symptoms, you're interested, and you want to spend some time in Boston, let me know. So what do we really need to talk about today? Actually, not much. We've got really 4 strategies that are to the point where we can actually start to talk about trials and where we're going and what we're going to do. So when we look at getting from the lab to market, where are we? And these strategies are, 2 of them are gluten-based because we know gluten is important. So can we neutralize gluten? Can we digest gluten? And then we know that gluten is getting in, so can we affect the barrier? And then finally, is there some way we can modulate the immune system? So taking these classes one by one, I want to show a little bit of the data and also talk a little bit about how trials are organized. So if you're thinking about being involved in trials, you can have some idea of what typical trials typically entail, because there will be more opportunities for trials coming in the near future. BL7010 is really a gluten blocker. The idea is gluten is in the inside of the intestine. If you could somehow stop it from being absorbed, then could you stop the immune response? And we don't have a lot of data on this, so the next idea is gluten digestion. You've heard already today that humans don't have in their digestive tracts enzymes that break gluten up into small pieces very well, which means that there's pieces that are left that are large enough that they can stimulate the immune system. And so is there some way that you could chop those pieces of gluten up so that then they wouldn't be there anymore and you wouldn't be stimulating the immune system? And so fortunately, bacteria actually have enzymes that are very good at cutting bonds between the types of amino acids that are in the portions of gluten that cause an immune response. So there's a first generation and a second generation of these enzymes. The first one is something called ALV003, and this is some data from the phase 1 study. This is actually a combination of two enzymes, ALV001, ALV002, because there's a lot of prolines and a lot of glutamines, so one's better for one than the other. And what you can see, this is a study where people had the enzyme and they had gluten, and then 30 minutes later, they aspirated their stomach contents, so they took out what they'd eaten, and then they tried to measure the gluten in it to see how well it was digested. And you can see, on average, about 10% of the gluten was left. So it looks like it's working, but is it working well enough? So the next step is a phase 2 trial. And so this is a randomized trial, meaning patients are randomly assigned either to the placebo or the treatment. It's double-blind, meaning neither the patients nor the physicians treating them, nor the people who are looking at the data know who's in which group until they unblind it. And it's placebo-controlled, meaning that some people get active treatment and some people get placebo, so we have something to compare it to. So this particular study was a 6-week challenge. There was a screening period at the beginning, a biopsy, and then after 6 weeks, another biopsy, because the primary outcome was how tall were the villi and what did the biopsy look like at the end. Patients got 6 grams of gluten a day, which is roughly equivalent to half a slice of bread, so a clinically relevant amount, particularly if we're thinking about the amounts that people are getting with cross-contamination, which is likely much less than this. I wanted to take a step back and talk about histology, because in clinical trials, we talk a lot about villus height-crypt depth ratio, and you might have heard your physicians talking about something called MARSH, and the two are related, because essentially what happens in celiac disease is if you're healthy, you have nice tall villi that are absorbing, and then you have crypts, which is where the intestinal cells are born, and then as they grow up here, they differentiate to become grown-up cells that do all of the absorbing functions in the intestine. When you have celiac disease, it's these mature cells that are intact. These dots are the intraepithelial lymphocytes, which are coming in and attacking the cells, and so you have increased, so these cells die, so you lose your villi, and you have more crypts because they're trying to regenerate to grow that back. So normally, your villi should be twice the length of your crypts, and if it's less than that, we consider it to be villus atrophy. Some people would say 3, but 2 definitely people would recognize as abnormal. So in this particular study, you can see in the medication, when people got gluten, their villi stayed about the same height, and those who had placebo, their villi got shorter, indicating that most likely the medication was protecting them from damage. So they then did another study, which was similar, except in this point they're looking at symptomatic patients, so they're looking at a particular group, and they have a range of doses, because we're now moving forward towards trying to get a treatment, and there's more questions to ask. And you'll notice this particular study had a very long run-in period, which is important. So again, one of the outcomes was villus atrophy, and it looks here like at all of the doses we're getting a little bit of an improvement. Now, all of these are 0.1, 0.15, and I can tell you in our experience, this is probably the difference between 2 people measuring the same thing, so it's really hard to know if this is actually clinically significant. And the important thing about this is that there was a placebo group, and actually, in the placebo group, their villi grew even better than the people who had the medication. And so this tells us something very important, which is that we can all probably do better with a gluten-free diet. They also looked at symptoms, which again, there wasn't necessarily a difference between treatment and placebo, but very importantly, out of this trial, they developed a symptom measure which meets FDA guidelines, so we now have a tool for future trials. There's another enzyme that's come along which has been engineered, so they've taken an enzyme and then they've studied how it works and changed some of the building blocks of it to make one that works better. So you can see on the left, this is a comparison, how well does it digest. So the black line on top is the alvine enzyme, and then this new enzyme is the red one, and you can see that it's lower because it's digesting more of the gluten. So almost 100% of the gluten is gone, and you can see on the right that this happens in the body, and it happens within 5 minutes. And so, it happens at body temperature within 5 minutes. So this is promising and something that's going to be moving forward relatively soon to more trials in humans. Finally, we've talked a lot about tight junctions and zonulin, and so one of the treatments that's been proposed is lorazepatide acetate, and the idea is that, this is the lumen again, this is the gluten. If it's getting between the cells, if lorazepatide acetate helps stick those cells together, can you then prevent it from getting across, interacting with the TTG and the T cells, and causing damage? This was the trial. Their outcome was intestinal permeability, and there was maybe some improvement in symptoms, but no change in intestinal permeability, so it's really hard to know what we're really looking at. In a subsequent trial, there was no difference between lorazepatide acetate and placebo. The 0.5 milligram dose is the black line, and placebo and the higher doses really are the same. Finally, there's moderating the immune system, and so there's vaccines which have been tested, and there's not a lot to say about this other than that they're currently looking to develop it for people who already have celiac disease as opposed to preventing, which is how we often think about vaccines. So what's else in the pipeline? Nanoparticles are another way of modulating the immune system so that instead of attacking gluten, it tolerates it. I also wanted to mention probiotics because there's not very good data on probiotics, but we do know that some probiotics can be contaminated with gluten, so probably not something to be trying outside the context of a trial. So what have we learned? We know that patients need more than a gluten-free diet. We know that how we measure the outcome matters, and we know that most could be more adherent to a gluten-free diet, especially if somebody were watching them, because when we put people in a gluten-free diet in a trial, their villi get higher, which suggests that maybe they're not having gluten. So when you eat gluten, this is this 33-mer sequence we keep talking about, it's in your food, but it's actually in your urine and in your stool as well. So we can test for gluten in your urine and in your stool. When that's been done, and these studies have been conducted in Europe, we see that actually about 30% of people who are coming for a clinic appointment who have celiac disease have detectable gluten peptides in their stool, which there's only one way that gluten peptides can get in your stool, and that's your mouth. And so this suggests to us that there's a lot of people who are trying to follow a gluten-free diet who aren't necessarily being successful. And this study also looks at whether or not the dietitians can identify these people, and they can't. Not surprisingly, children do better than adults. And the longer you've been on the diet, you don't really get any better. So our next project is something we're calling the DOGGIE bag study, which is a determination of gluten grams ingested and excreted by adults eating gluten-free study, which is really just that. So our participants are collecting food, stool, and urine, and then we're looking to see if there's gluten in it. And hopefully, these are some of our samples, hopefully we'll have some results soon. And the crystal ball says we're going to the all-you-can-eat buffet. How are you going to get there? We need you, we need volunteers, because you can't do trials without people. And so be involved. This is actually some of the participants in our Canadian study. We need to have you in this seat and participating in trials in order to move things forward. So thank you. This is on the top, our group in Boston, and on the bottom, our group in Canada. Thank you.